Okay. Welcome everyone to this session on the early use of vasopressin. Dr. Tolwani and myself, we are very happy to moderate this session. So we are on a tight schedule. That's the only vasopressin joke I could come up with. So let's start with the first speaker, and we will go to Dr. Duranteau for the first speaker, and he will talk about vasopressin in traumatic hemorrhagic shock. The floor is yours.
Thanks a lot. So what about vasopressin in hemorrhagic shock? So when we have to deal with hemorrhagic shock, we try to be in a damage control resuscitation strategy. So we try until the bleeding is controlled, not to give too much fluid, and to try to maintain an arterial pressure, not too high, to not increase the bleeding. And we use a lot vasopressor to try to get this target of mean arterial pressure without giving excess fluid. And until the bleeding is controlled, we know that it could be deleterious for regional circulation, but the idea is to give time before arriving at the hospital and before to be able to stop the bleeding. After controlling the bleeding, it's another story, because we can have to face to vasoplasia and organ dysfunction. So we can use vasopressor, but for other reasons. So initially, I think it's important to keep in mind that when we have an hemorrhage, the sympathetic system is activated, and by this way, we involve all the vasopressors that we have: norepinephrine, vasopressin, and angiotensin II. And most of the time we believe that the sympathetic tone is increased when you have a decrease in arterial pressure. But it's not completely true. It's involved largely before. It's involved when we have a decrease in the venous return, when we have a decrease in the PVC, independently of the mean arterial pressure. The mean arterial pressure could be stable, but if we have a decrease in the venous return, you have an activation of the baroreflex inside the heart, and we have a stimulation of the sympathetic tone. And this is very important to keep in mind, because the involvement of the three vasopressors start before we had a decrease in arterial pressure. The second thing to keep in mind is that we talk about vasopressor, but it's not only vasopressor. Vasopressin is not only a vasopressor. Angiotensin II is not only a vasopressor. It's a vasopressor, but also it's deeply involved in the response to hemorrhagic shock by increasing the reabsorption of water and sodium at the level of the kidney. And once again, this response starts immediately when you have an hemorrhagic shock. There is no delay. So vasopressin help to stabilize arterial pressure, but also to increase the fluid inside the vascularization. And just to highlight the fact that the three vasopressors are very quickly involved. It's a study that we performed a long time ago. It's in healthy volunteers, and we induce progressive decrease in venous return with a lower body negative pressure. And you can see that there is 3 steps where we progressively decrease the PVC. and this induced a decrease in cardiac output, but the arterial pressure was completely stable. So no variation of arterial pressure. Okay? So just a decrease in venous return. And you can see the activation of norepinephrine is involved from the start when you have a decrease of around 1 point of PVC, so very quickly. But if you look at the renin activity and the arginine vasopressin inside the plasma, you can see that it's involved when you have a decrease in PVC of around 4, and still the arterial pressure is keep constant. So I think it's important to understand that sometimes we think there is a delay. There is first the sympathetic tone, and after a delay of 20 minutes, there is the activation of the renin, and after there is, when it's very deep hemorrhage, there is an activation of vasopressin. The story is not this one. You have from the start an activation of the 3 vasopressors. So just to highlight the fact that vasopressin is a very crucial actor in the response of hemorrhagic shock, this is the dosage of copeptin, which is the C-terminal fragment of arginine vasopressin. It's easy to detect than vasopressin, and it's in the emergency room, so it's the first sample when the patient, the trauma patient, arrives at the emergency room. And you can see that they compare the predictivity of copeptin versus lactate. And you can see that copeptin is largely a better predictor concerning the severity of the trauma, concerning the hospital admission, and concerning transfusion. So concerning the importance of the hemorrhage. Largely better than lactate. And this very quickly. So it's the first sample at the emergency room. And so it's the vasopressin is very quickly involved. And the problem is that maybe there is a deficiency of the vasopressin when the shock is very important and we are not able initially to control the shock. And this is highlighted by this study where they define the fact that there is an arginine deficiency when you have during the first 2 days of after admission, the patient is still hypotensive and with a low concentration of arginine vasopressin. So they distinguish 2 groups, and when the groups where they detect a vasopressin deficiency, you can see that the group was largely the more severe group with a high lactate level and a huge consumption of blood product. So the idea is that when you have to deal with a deep hemorrhagic shock, maybe there is not enough arginine vasopressin. So it's an argument that we have to add vasopressin in this kind of shock. So in my unit, we test the concentration of copeptin in hemorrhagic shock patient, in trauma hemorrhagic shock patient, and you can see that at the initial management of this patient, you can see that the level of copeptin is highly dependent on the severity of the shock, highlighted by the number of red blood cells in this patient. And you can see that 6 hours after, it's the same in every group. 6 hours after. 6 hours after, it's when you have to deal with a big hemorrhagic shock. You control the hemorrhagic shock, but the patient has still vasopressor, and the story is not over. But the vasopressin is normal at this point. So for me, it's it's really a strong argument to think that there is a deficiency in hemorrhagic shock. And there is only a small quantity of animal study. Just I want to show you this study because it's an extreme study. It's in pigs. They induce a huge hemorrhagic shock, and after they wait 30 minutes, doing only one thing, introducing vasopressin. No fluid, nothing. So just try to keep time for the patient and it's the idea before performing stopping the bleeding. And what you can see is that it's increased the arterial pressure. They use in another group adrenaline, and adrenaline fail to restore arterial pressure. And look at the regional circulation. You can see that the portal vein is deeply decreased, but progressively there is a small restoration, and at the hepatic artery blood flow was immediately largely higher than the number before hemorrhage. And you can see that at the level of renal artery, you have a small recovery, but when these animals are resuscitated, you have complete recovery of all the flow. So this is without fluid. So we give fluid in patients. So in patients, if we use vasopressin, I think we will have better result during hemorrhage at the level of regional circulation. So this study in human, where it's a randomized control study where they use vasopressin as a first vasopressor, and they found that they were able to give less fluid, but the study was stopped because not enough recruitment, and it was difficult to make conclusion on mortality or even transfusion. It was the same in both groups. And this randomized control study where they add to they use norepinephrine as the first vasopressor, and they add systematically in one group vasopressin at low dose and versus placebo. And what they observe that you can see just this slide to show you that it's really hypotensive patient with a very high lactate level, so it's high hemorrhagic shock. And what they observe that by this strategy, they can reduce for 1 liter transfusion. 1 liter, it's huge. And it was true for red blood cells, it was true for FFP, it was true for platelet, and they also reduce the amount of norepinephrine. But 1 liter, it needs another story to confirm this result, but 1 liter, it's very impressive. And 1 liter, is it because the vasopressin is a magic vasopressor? I'm not sure. It's maybe because vasopressin acts at the level of hemostasis, because vasopressin is capable to boost coagulation, is capable to boost the function of platelet. So I think it's why it's important not to consider vasopressin only as a vasopressor, but it could also act at the level of hemostasis, and it could explain this very nice result. And so we are always afraid that by applying a vasopressor, we can induce deleterious effect, and they observe no deleterious effect, and they were even less deep venous thrombosis in the group of vasopressin, and you can see there is a nice signal at the level of acute renal failure. It was non-significant, but it's interesting to see this. So to conclude, I think it's important to try to correct the deficiency of vasopressin that we have during hemorrhagic shock. It's important maybe to avoid the large amount of norepinephrine that you give right now when we have to deal with a deep hemorrhagic shock. It could be a balance, a mere balance between the pressure effect and also the fluid effect. And we have always in mind that it could protect the renal function. And we are waiting to start two protocols in France about on vasopressin in trauma patients to see if we have beneficial effect at the level, especially at the level of the kidney. And remember that it's improved coagulation, so I think this is a crucial point. And it could, when we have to deal with a very deep hemorrhagic shock with organ failure, and you can see that the norepinephrine is not sufficient to maintain arterial pressure, it can offset downregulation of adrenal receptors. Thanks a lot.
Thank you for that excellent talk that we just had. Since we started this session late, what we're going to do is hold questions till the end, just in order we can get ourselves back on time.
Thanks a lot.
So I'm now going to introduce the next speaker. It's Dr. Rinaldo Bellomo, who's going to talk about vasopressin as a first-line agent. Thank you.
Thank you very much, Ashita. So vasopressin, vasodilatory shock is a controversial topic. Its value really has been defined by two large trials, the VAST and VANISH trials, but these trials involve different populations and ultimately, for the standards of today, were underpowered. And there's been persistent debate not only about whether vasopressin should be used, but when it should be used. Just to remind you, the VAST trial was published 16 years ago and involved only 776 patients. And as I said, for today's world, they will be underpowered, and also looking for a 10% absolute difference in mortality is unrealistic. Nonetheless, even though it was underpowered, you can see that the follow-up at 90 days in the trial appeared to show a potential difference with a P of 0.1, which in a Bayesian analysis would suggest a 90% probability of a beneficial effect. However, even within the limitations of the trial, and you've seen Jacques Duranteau talking about a potential renal effect in the subgroup of patients presenting with kidney injury, the administration of vasopressin in the context of vasodilatory shock was associated with a better recovery of renal function and, in that particular population, even a potential survival advantage. But of course, this is a small group of patients. The VANISH trial was a 2x2 design of hydrocortisone and vasopressin, but nonetheless, it was interesting in the sense that, like the VAST trial, it showed a potential benefit in terms of kidney function with a reduction in kidney failure-free days compared to the control population of placebo. So twice in two studies of vasodilatory shock, we were able to demonstrate, or the investigators were able to demonstrate a potential renal beneficial effect, and this is a recurrent theme with vasopressin. More recently, we reviewed all the literature about the concept of using non-adrenergic vasopressors, and there are other issues that surround vasopressin itself, and that is, it isn't just vasopressin and what it does or what it may not do, but what reducing the exposure to adrenergic vasopressors like adrenaline or adrenaline might do to decrease the potential toxicity associated with these agents. And again, there is a signal in favor of not using adrenergic vasoconstrictors. Gretchen Sasha from the Cleveland Clinic looked at a large data set from hospitals within their system, and they looked at the timing of intervention now with vasopressin. And you can see there that if you intervene at a lower lactate, you have a better outcome and you decrease mortality. And if you intervene with vasopressin at an earlier time of initiation, earlier time from admission and presentation with septic shock, you also have a decreased mortality in different bands of lactate. So earlier initiation of vasopressin in patients who receive vasopressin, despite higher lactates, is associated with better outcomes. So that's promising. More recently, the Cleveland Clinic reviewed the area and looked at the initiation of vasopressin in relation to lactate level and in relation to different dosages of norepinephrine equivalent, and again demonstrated a decreased risk of in-hospital mortality at different levels of vasopressor administration, showing that earlier intervention defined by a lesser dose of norepinephrine or defined by a lower level of lactate is associated with better outcomes. And these findings and these observational data are in contrast with the remark of the Surviving Sepsis Campaign guidelines that gives a weak recommendation, that's okay, but also says in our practice vasopressin is usually started when the dose of norepinephrine is in the range of 0.25 and 0.5. This is way away from what you see in the Cleveland Clinic data. So I live down under, so Australia is a very different place from the rest of the world. We're far away, and we've got kangaroos and koalas, and you want to find out whether what we do in Australia is similar to the Cleveland Clinic or whether it's similar to the recommendations of the Surviving Sepsis Campaign guidelines. We can do that because in the state of Queensland there is a coordinated data set for intensive care patients, and Rahul Costapinto is conducting a PhD on this topic. Where is Queensland? Queensland is there. Brisbane is the major city in Queensland. It's a gigantic state, about the size of half of Europe. It's got 7 million people, and they make up about 25% of the population of Australia. It has a database of all patients admitted to ICU over the last 7 years. This is 90,000 patients, and you can identify those who receive vasopressin in the first 72 hours, and then exclude a few people that do not have septic shock, remain with about 2,700 patients with septic shock, and divide them according to early vasopressin therapy and late vasopressin therapy. So the first observation is that in Australia and New Zealand, we're more like the Cleveland Clinic than the Surviving Sepsis Campaign guidelines. The majority of patients, as you can see, are started early rather than late with vasopressin therapy. These patients are sicker. The people where we start earlier have got a higher Apache scores and have got higher lactate levels compared to those where the intervention is late. The median vasopressin time across the whole of Queensland is really short. 3 hours. So we're like the Cleveland Clinic and not like the recommendations. So what happens when you give vasopressin to people? So we got data every hour. We've got data every hour on the heart rate, for example. And you can see that when you start vasopressin, whether you start late or whether you start early, there are physiological changes that take place. And these physiological changes subvert, if you wish, what was happening before you started vasopressin. And you can see that is true whether you start early or you start late. And the same is true of pH, and you can see that the pH change, pH is going down, and you start vasopressin when you start early or you start late. Again, there is a response which is physiologic, which is likely to be related to vasopressin rather than the course of the patient's illness, which is modified by the initiation of vasopressin. And of course, once you start vasopressin, very quickly you change the vasopressor dose with noradrenaline. You can see that for early or late vasopressin initiation. Both of them have got a similar slope, and you can see as soon as you start descending with the dose of noradrenaline, which was escalating before you intervened. And again, we have the same association between the timing of starting vasopressin and the probability of hospital mortality that you saw in the Cleveland Clinic data, and it's a linear relationship. The sooner you start vasopressin, the less your mortality is. As you wait, and wait, the mortality starts going up. But of course, this might be because the doctors that wait a long time are really bad doctors, or they wait a long time because they are certain about diagnosis, or they wait a long time because of other factors. So this is not necessarily the cause. The vasopressin is not necessarily the cause of this decreased mortality when it is started early. But when you see data like this, you have to worry that there is a real potential benefit of vasopressin. And when you do a multivariable logistic regression model and you look at all the predictors of mortality in this population, in Queensland you find that the early start of vasopressin is associated with a 30% relative risk reduction in mortality after you've adjusted for all of these factors that you see in this slide. And you can see this Kaplan-Meier survival curve supporting the view that early vasopressin therapy is the right thing to do. Now, statistics have evolved a lot, and statistical modeling and the understanding of potential causality for an intervention can now be investigated with a new form of statistical technology called target trial emulation. We're lucky to have Anis Shabat from Paris doing a fellowship with us, who has significant expertise in this kind of statistical technology. If you want to read more about the concept of target trial emulation, there is a recent review in the New England Journal of Medicine in November and a nice review in JAMA a couple of years ago about how this technology may give us a better idea of, or a better way of using large observational data to make causal inferences about what happened. So how does it work? Again, we select the patients with septic shock. We include that in the target trial emulation. And what you do is you create models that can take patients that did not receive vasopressin or received late vasopressin, and you can create a time zero equivalent for these patients. Then you simulate the course of their ICU in the pseudo population with Monte Carlo simulation to create a counterfactual of what would have happened to these patients that did not get vasopressin if they did get vasopressin. And you could simulate what would have happened to the patients that got late vasopressin if they got early vasopressin. And then you can use bootstrapping technology to create confidence intervals, and you can also dynamically adjust for time-dependent covariates which might affect the initiation of vasopressin therapy. And so you can create these dynamic models of counterfactual reality using these simulations and bootstrapping for confidence intervals and Cox adjustment in a dynamic way by covariates to create two worlds that don't actually exist but might have existed by creating a simulation of reality. And this gives you an idea of the counterfactual reality that would have happened if you never use vasopressin, for example. And if you do that, you can find that in a world that you never, where you would never use vasopressin in equivalent patients with septic shock at an equivalent time, there is a signal in favor of giving vasopressin, but the effect is relatively modest with a 5% relative risk reduction. But even within this model, there is a signal that early vasopressin therapy is better than delayed vasopressin therapy. You can see that demonstrated in this graphic representation. And again, if you look at populations that at time zero have got specific characteristics in the simulated reality, you find once again the starting at a lower lactate, starting at a lower dose, starting at a lower level of Apache score is beneficial, and it's beneficial in people with or without mechanical ventilation. It's a consistent observation that this intervention is superior. And this is another demonstration of the dose of norepinephrine at intervention. And if you extrapolate all of this, you come to the observation that the best time to start vasopressin may be as you start norepinephrine. And that vasopressin is a potential adjunct therapy that should be started from the very beginning in people with vasodilatory septic shock. And you can also see here in the simulated target trial that if you give vasopressin at earlier time, you can see the green slope there. The slope of improvement in vasopressor requirements is steeper. And you can see that, again, demonstrated in noradrenaline dose, it's the same as steeper curve of improvement. So let me conclude by saying that we've got recurrent, robust, and large observational data that show that early initiation of vasopressin in patients with vasodilatory shock is statistically significantly associated with a decreased risk of death. Early is better, both in terms of dose and time, and carries a strong association with improved survival, which gets progressively stronger as the intervention begins earlier and earlier. This finding was also present in the VAST study. We've now demonstrated the robustness of this concept in a target trial emulation statistical analysis. The earlier, the better. In patients with the shock, this implies that potentially simultaneous initiation of vasopressin and norepinephrine may be a superior approach and, of course, should be tested in future randomized controlled trials. Thank you. I know you want to delay questions, but I have to go to another place, so for another presentation.
So please, if you have a question for Professor Bellomo, try to find him at another session and pose your question.
Okay, bye.
He will be around. He will be around. Don't chase him until Australia. That's a recommendation. So thank you very much. And we will now move to the next speaker on is the early administration of vasopressin so important? So tough job for you, Dr. Grasselli, but please go ahead.
Thank you. Yes, indeed, it's quite difficult now because, I apologize, but I will have to repeat many of the things that you've heard from Professor Bellomo, but at least I want to reassure you that we are along the same line. So these are my conflicts of interest. So a little bit of background. We're talking about mostly septic shock, which is a form of vasoplegic shock. You know that vasoplegia is defined as a situation with low systemic vascular resistance, resulting in hypotension with normal or even increased cardiac output. But when this is associated with tissue hypoperfusion, like lactates, for example, production in septic shock, this is called vasoplegic shock. So we all agree, I guess, that these are the cornerstones of the treatment of sepsis. So we should early recognize sepsis. We should early institute an adequate antibiotic treatment. We should provide early and complete source control. And finally, we need to give to the patients early hemodynamic resuscitation, and we will obviously focus on this. So we need to give the patients early antimicrobials, source control, fluids, and vasopressors. And we will mostly focus on this. The physiological rationale behind this is that what we want to do, we said that shock is characterized by reduced tissue perfusion, and so what we want to do is to optimize the oxygen delivery to the tissues, and you know that oxygen delivery is cardiac output times the concentration of oxygen in arterial blood. So we said, okay, we need to give fluids and we need to give vasoactive drugs. We have problems with both because we know that positive fluid balance is associated with worse outcome, is associated with increased risk of acute kidney injury, with metabolic disturbances. And this is a very interesting, if you carefully read the Andromeda shock study published in JAMA a few years ago, Well, the trial was about, a new target of resuscitation and in particular capillary fill time. But if you look at the data, because they carefully assessed fluid responsiveness, it turns out that only 1/4 of the patients remain fluid responsive after the initial fluid resuscitation. Well, so we also have problems with vasoactive drugs, especially with adrenergic agonists, because you know that all the catecholamines target the same adrenergic receptors. There is impaired sympathetic modulation of the heart and the vasculature. The response to vasopressor is different from patient to patient. If you give to the patient excessive doses of vasoconstrictors, you will increase left ventricle afterload, and you will enter into a vicious circle of excessive adrenergic tone that in the end will worsen hyperperfusion. So what are the possible solutions for this? Well, one is to give patients less fluids, and I will not discuss this, but you know that there are studies, even big ones, published in the New England Journal of Medicine, that seems to show that a restrictive fluid strategy, even in septic shock, is not inferior to a liberal fluid administration. The second point would be we maybe administer earlier vasopressors, to use different vasopressors, and to use different targets for resuscitation, and we will focus on the second and third point. So first of all, should we give earlier our patients vasopressors? Well, there's a rationale for this. Clearly, if you give patients earlier vasopressors, you shorten the timing of the duration of hypotension. You always reduce, and you reduce the amount of fluids that you have to give to the patients, and you possibly improve microcirculation and ultimately tissue perfusion, that I remind you is the final driver of the organ dysfunction that we observe in these patients. So there are data that support the earlier administration of vasopressors. Most of the data are with norepinephrine. There are preclinical data. These are just to show you, there are data in animals. This is one sheep model, one rat model, both with endotoxin infusion, and they both basically agree that if you give norepinephrine earlier, then you can reduce the amount of fluids and you improve mesenteric blood flow, which means you improve organ perfusion. There are data in humans. I'm not going to show you the single trials, but this is a very recent meta-analysis published in Annals of Intensive Care that pulls together 11 studies. 2 are 2 randomized controlled trials, the 2 studies on vasopressin that Professor Bellomo showed before, and 9 retrospective studies. 3 of them are called quasi-experimental studies because they use the propensity score matching of patients, so they are considered sort of similar to randomized studies, despite being observational trials. Okay? So, of course, there was a huge heterogeneity between the different studies in timing of administration, type of vasopressor, combination of vasopressors, and so on, and also in the protocols of fluid resuscitation. The primary outcome was short-term mortality, and we can also discuss whether this is a good outcome. But anyway, so they decided to meta-analyze the 2 main randomized studies plus the 3 quasi-experimental studies, and in total they put together almost 4,000 patients. And what they saw was that early vasopressin was associated with reduced mortality in the entire population, but not in the quasi-experimental studies. When they did a sort of sensitivity analysis, they observed that lower mortality with vasopressin administration was observed when the drug was started between 1 and 3 hours, and in studies using septic shock. So these are the recommendations of the Surviving Sepsis campaign, and I'm not going through this, but I wanted to point to observe that there is a suggestion that you can start norepinephrine with the peripheral line. So the idea behind this is that you should not wait for the insertion of a central venous catheter to start norepinephrine, and this, of course, opens the door to the earlier administration of norepinephrine, also in patients who are not equipped with a central venous catheter. So this was about the early administration of vasopressors, and most of the data, as I showed you, were with norepinephrine. Now, the second point would be that maybe we should combine different vasopressors, and there is a strong rationale for this, because we know that pathophysiology of vasoplegia in these patients is multimodal, follows different pathways. It's not only a vascular hyporesponsiveness, which is and deregulation of adrenergic receptors, which is the reason why we give adrenergic agonists, or a reason why we give catecholamines. There is a deficit in the renin-angiotensin-aldosterone system, so which is the rationale why we are now testing angiotensin II. There is a problem with the NO, nitric oxide pathway, and now methylene blue is coming back in the field, and also there is a deficit of vasopressin, and now we know that the second vasopressor that we should add to norepinephrine is vasopressin. We have data on this, yes. This is the VAST trial. Professor Bellomo already showed you the trial. It was published in the New England Journal of Medicine, double-blind randomized study on almost 800 patients with septic shock after fluid resuscitation plus norepinephrine, starting from very low doses. You can see there, 5 mg per minute. And these patients were randomized to receive vasopressin at the dosage recommended by the Surviving Sepsis Campaign guidelines, or to increase the dose of norepinephrine. The primary endpoint was 28-day mortality. There was no difference in the entire population, but interestingly, they observed an advantage for the use of early vasopressin in the subgroup of patients with less severe shock. So those patients who are receiving lower doses of norepinephrine at randomization. You have seen this already. This comes from the study from Sasha on more than 1,600 patients who were treated with vasopressin as an adjunct to catecholamines. In this study, the median time from shock onset to vasopressin administration was 5 hours. And what they found is that starting vasopressin at lower norepinephrine equivalent doses or lower lactates is associated with a significant reduction in mortality of the patients. There is another interesting study, I think. It's published in Shock 3 years ago now, almost 400 patients who were treated with vasopressin within 48 hours from the onset of septic shock. The median time was 7 hours. So they divided the population in two, those who received vasopressin before 7 hours and the others who received vasopressin after 7 hours. And the primary outcome was a composite of SOFA improvement and hospital mortality. And if you look in the table, you see that most of the outcomes were significantly in favor of the earlier administration of vasopressin. And in particular, of course, the duration of norepinephrine, but also the duration of mechanical ventilation, the risk of acute kidney injury, ICU length of stay, mortality, and so on. You can see on the right-hand side of the slide the graph that shows an almost linear relationship between mortality and timing of administration of vasopressin. So you may have heard this yesterday in the opening ceremony. I'm very happy for the authors that got their papers published in JAMA. I'm a little bit less happy for myself because I had to change my slides yesterday night. But this was published yesterday in JAMA, and it's the obvious reinforcement learning study. I must confess that I barely know what a T-student test is. So for me, it's been very, very difficult to understand how they did this. But anyway, so what they did was that they put together a huge, enormous number of data, and they applied some machine learning algorithm to what they called reinforced learning model to generate a sort of optimal rule for vasopressin administration. So, if I understand well, they were able to, let's say, describe a sort of recipe on how to use vasopressin in these patients. It's more than 14,000 patients. There is a derivation cohort on 3,000 patients, and then a validation cohort taken from very large and open access, actually, databases. These were all patients who were already on norepinephrine. And as you can see there, clinicians decided to start vasopressin in 30% of these patients. Vasopressin was started in this population after a median of 5 hours after shock onset, and at a median dose of 0.3 milligrams per kilo per minute of norepinephrine, and when the patients had a median lactate level of 3.6. So I would say that in this percentage of population, it's in line or even at lower doses of norepinephrine as recommended from the Surviving Sepsis campaign. Professor Bellomo told you that the guidelines say that we should start vasopressin when after 0.5 milligrams per kilo per minute of norepinephrine, and we are all stuck in this problem of the norepinephrine base or norepinephrine tartrate, because as you know, for example, in Italy we have norepinephrine bitartrate. So the potency is half of that of norepinephrine base, but anyway. So the hospital mortality in this cohort was between 30 and 43%. The picture is very nice for the colors, but it tells you that compares to what the physicians did based on their clinical judgment, okay, if they had the optimal rule that was produced by the algorithm would have suggested to use vasopressin in 87% of the patients instead of the 31%, earlier in time, so 4 hours instead of 5 hours after shock onset, and at lower norepinephrine doses. And there was also a strong signal in terms of the reduction of hospital mortality if vasopressin was administered according to the algorithm instead of the clinician's judgment. So, in conclusion, I think that there is a rationale for the earlier administration of vasopressors because it's associated with reduced amount of fluids, shorter hypotension time, and reduced mortality, possibly. We are moving towards a multimodal treatment of septic shock with probably different drugs that act on different mechanisms in order to avoid an excessive adrenergic tone. There is evidence now, I think, that suggests that vasopressin should be administered earlier to a higher number of patients and should be started probably when we are at lower doses of norepinephrine. And of course, this is popular now. We say it in every session, in every presentation. We should aim to personalize the resuscitation protocols for the patients. Thank you very much for your attention.
Thank you for that excellent talk. Now that we've heard about these wonderful speakers talk about the use of vasopressin as first line, let's now look at a more practical approach. So I'd like to invite Dr. Arthur van Zanten up to tell us what he does. Thank you.
Well, I will show you some information about a registry we performed from daily life intensive cares in the Netherlands, Italy, and India, because we came up with the same questions. Which patients do we need to give it, and at what kind of norepinephrine dose you want to start? How long will be the shock duration? Do you see side effects, and so on? So these are my disclosures. So we received an educational grant to build this registry from AOP Pharma. I will go directly to this topic already mentioned. Some countries use norepinephrine as norepinephrine tartrate, and then it's not always reflected as norepinephrine base. So in the Netherlands we use norepinephrine tartrate, but the amount is still stated in base. And so to compare all the studies, we have to go for norepinephrine base to have comparability all over the world. So it depends on in which country you are what is the real dose of norepinephrine base. So when you want to have like some effect of vasopressin as a second-line vasopressor, you have to consider when you think norepinephrine is too high. And we learned that maybe we have to start immediately, but typically we start with norepinephrine, and at a certain point you think it's too much. But nobody knows when. So some people call it refractory shock or catecholamine resistant shock, and nobody knows where is this threshold, of course. So in the Netherlands, typically people use around 0.25 micrograms per kilogram body weight per minute. It's also dependent on the target mean arterial pressure. So if you aim for 65, you need maybe less than if you go for 80. That's very logical. So the Surviving Sepsis campaign, already addressed by the previous speakers, says, well, you can use between 0.25 and 0.50, but it can be rather late, and we wanted to see what is the practice in the sites, and is it really a good target to start. Let me see. Can we identify the patients on baseline who will have a hemodynamic response? And it's difficult because the vasopressin levels in the blood do not predict the response to vasopressin with respect to blood pressure. So that's not very helpful. So we started this registry, 200 patients in 11 centers, mainly from the Netherlands. There was a lack of data from Europe. We've seen data from Australia and from the US, but it's good to have some data also from Europe. So it will give you some insights in the hemodynamic response. So how many patients respond with the blood pressure stabilization or a reduction in the norepinephrine dose. Typically, blood pressure goes, norepinephrine levels go up and up and up in these shock patients, and you want to get it stabilized or going down. Shock duration is the total duration of the vasopressor therapy. Any vasopressor, can be norepinephrine, vasopressin, or others. And rebound hypotension is the phenomenon that when you stop vasopressin, that sometimes you see that you have an increased amount of norepinephrine infusion again. So by definition, we used within 2 hours after the stop of vasopressin. Now, we included in this study 200 patients, and we found, with using this definition of a stabilization of blood pressure or a reduction in norepinephrine within 2 hours, that almost 4 out of 5 patients show a hemodynamic response, and we only found 9% of rebound hypotension. Now, can we identify those patients who will be having a hemodynamic response? And I want to stress, based on the information that Professor Bellomo showed, it can be that also patients with a limited hemodynamic response can benefit with respect to mortality or renal function. We didn't address that. We only looked, can we see an effect on the blood pressure? So what we found that responders have a slightly higher norepinephrine dose. Doesn't mean that you have to start at the dose, but you see when the norepinephrine is higher, you will have a higher likelihood of seeing a response, 0.44 to 0.33 micrograms per kilogram per minute. Arterial lactate was lower in the responders, also shown in other studies, and there was no difference in the study with respect to arterial pH. We found strikingly also that there was a lower response in patients with a high BMI. This drug is typically not dosed per kilogram body weight, but we found in high BMI patients or obese patients a lower response rate. And well, it could be also in multivariable analysis this was seen. Arterial lactate, NOR dose, and obesity were factors associated with the response, the hemodynamic response. And from the VAST study, it was already known that the levels of vasopressin in obese patients can be lower. So maybe the dosages should be slightly higher in those obese patients. And there is one study also going to a higher level. Most sites used up to 0.03 international units of vasopressin. In this study, they used a higher dose, of 0.04, and so more hemodynamic response also. So maybe you can increase in the obese patients. Is there an optimal cutoff? In this cohort, we found the optimal cutoff for hemodynamic response was like 0.34. But actually, most sites had a protocol with 0.25 to start vasopressin, but the actual starting moment was much later, 0.16 of norepinephrine dose, higher than the protocol. So there is a delay you have to consider if you make a protocol that always when you want to start at a certain point, because the norepinephrine levels go up, you will start later in daily practice. What is the course of those patients after you start vasopressin? Now here you see, I don't know, it's going quickly. This is the time before the commencement of vasopressin, that's here. You see the groups are comparable with this upsloping norepinephrine demand, and here you see in the responders a 23% reduction in norepinephrine dose, and in the non-responders it has to go up further, and this is about 20% of the group, this is about 80% of the group, and in the initial phase you see a significantly higher mean arterial pressure after 1 hour in the responders. The arterial lactate is higher in non-responders and, slightly increases even and stays at a higher level. It can also be due to the effect of norepinephrine on the shuttling of lactate. It could be another factor, but it's always higher, the lactate in non-responders. And this was also found in this study by Sasha and all, showed by previous speaker. And in this study also the response on vasopressin was associated with lower mortality, more hospital-free days, better renal function, and a lower norepinephrine dose. And this has been shown also before. The earlier the start at a lower norepinephrine dose or at a lower lactate level, the higher the likelihood of response and the better the survival. So all pointing in the direction of an earlier start is beneficial. Now, what happens with the pH when you have a responder? It stays very stable at a rather high level, but in the non-responders you see progressive acidosis. So that's what we found here. And in this study it was shown that the response could also be associated with the pH. So the higher the pH, the higher the likelihood of seeing a hemodynamic response of vasopressin. This is the fluid balance, so non-responders need slightly more fluids. It's only 1.4 milliliters per kilogram per hour, but it's more than 1 liter over the first day after the initiation. So it seems that it also has an effect on the need or the demand of fluids. This is urine output. You see the urine output in responders is better than in non-responders, but this difference is not statistically significant. So what about the clinical outcomes? We found that there was a less new onset atrial fibrillation in the responders, 4% and 14% in the non-responders. And we also looked at the outcome of these patients with new onset atrial fibrillation, and we found that the mortality was higher in this group. This was also found in a meta-analysis published before. We found not so much serious adverse events. There were some events of digital ischemia, a few with myocardial and mesenteric ischemia, but we don't have a control group with only norepinephrine, and in this group you will also see this kind of side effects in 200 refractory shock patients. So this was also found in other studies, more digital peripheral ischemia, but I think you can also solve this by optimal fluid resuscitation. Now, the shock duration, we found that, I go back one, that the total duration of shock was exactly the same in responders and non-responders, but the patient with a higher pH showed a shorter shock duration, and also when the NOR infusion was less than 7 hours, we saw a shorter shock duration. So the earlier the start, the shorter the shock duration. This was also found in this study. When you start within 3 hours, there is a shorter shock duration. Now, rebound hypotension was very uncommon, only in 9% of the patients. And we found that it was more likely in those patients that received vasopressin for less than 24 hours. So it seems that the prolonged administration can prevent, in a way, this rebound hypotension. And it could be that it takes some time for the patients to solve this problem of this relative vasopressin deficiency. So it's also recommended by the company to give it at least for 48 hours, but most sites used it very shortly. So this is our practical protocol we use. Of course, you treat refractory shock with fluids, you do hemodynamic monitoring, and at a certain level you have to start. Maybe we have to start at the commencement of norepinephrine already, but we lowered this from 0.25 now to 0.20. You start with argipressin. You can go up in 3 times 15 minutes, depending on the response, to a highest level of 0.03. Maybe you can go to 0.04 in obese patients. When you have a sufficient mean arterial pressure, you go down, you taper the argipressin, and we go down only when the norepinephrine levels are lower than 0.10. So we go to a rather low level, because then you see less rebound hypotension. And we don't go to 0 because we see a lot of patients with sedation needing a little bit of norepinephrine, and then we want to remove the vasopressin first. Now the conclusion are, I showed you that in this cohort of patients we saw a reduction in the use of catecholamines, norepinephrine. We saw the optimal hemodynamic response at a norepinephrine level of 0.34, but it doesn't mean that it leads to the optimal outcome of the patient. So maybe we have to start even earlier. Early initiation at a higher pH level, at a lower lactate level, is better or associated with shorter shock duration. And a longer vasopressin administration is associated with less rebound hypotension. In this study, we didn't find, but it's a small study of 200 patients, no major effect on renal function or CRRT, but there are other studies showing this. So the take-home message is, I think norepinephrine can induce all kinds of side effects. It's immune paralytic. It has been shown that vasopressin has no effect on the immune system. It has cardiovascular side effects. You saw the effect on new onset atrial fibrillation. It has renal adverse events. I've shown you that we can reduce the norepinephrine dose, reduce the new onset atrial fibrillation. If you start at a higher pH, a lower lactate, and a shorter norepinephrine infusion, you have a higher likelihood of response, hemodynamic response, and probably also on the effects on outcome. Rebound hypotension is rare. I think the safety profile for such very sick patients is acceptable. We don't see major incidents of serious adverse effects. And my final conclusion, and it was very helpful that Rinaldo Bellomo already discussed this, I think maybe we have to progress to the multimodal vasopressor therapy, meaning that we have to start treating septic shock immediately with 2 vasopressors, and then we have to consider which one to taper first. Of course, we need RCTs, but the observational data is compelling. There's so many studies now all suggesting earlier start in less sick patients leads to, earlier stabilization, shorter shock duration, less side effects, and even a reduction in mortality. So I think that's the way to go forward. And with that, I'd like to conclude, and thank you for your attention.
I want to thank you for that excellent talk. Do you have time to stay for 1 minute or two for any questions that may come up? Are there questions in the audience? I know we're at the time of the end of this session.
There is a question.
Okay, there's one question here. We have time for maybe 1 or 2. Did you hear what he said?
It's on the timing. Otherwise, please
come
stop
up.
here.
I
Because
couldn't hear it. I'm sorry, but...
Sir.
Maybe use the microphone.
Thank you so much.
even when the noradrenaline requirement around 0.1 mite per kg per minute, do you recommend to start vasopressin early if the lactate level is high, kind of things?
You mean the start or the stop?
Start.
The start, yeah. Well, we in our unit, we now gradually reduced already to 0.20, but maybe based on this information from Australia, we should go to maybe 0.10 or maybe start immediately. The problem is we don't have an RCT now with the co-administration of vasopressin from the moment we need vasopressors in septic shock. So it's now, most studies have been performed with a sequential start. So first norepinephrine after resuscitation and then vasopressin. But what Professor Bellomo told, we have to do a study to start them both and compare with a later start or no start of vasopressin, maybe a 3-arm study, and then to see what is the best result with respect to organ failure and outcomes. I think that's the way to go forward.
Is there any question for another author? Please, sir. Yes?
Maybe you have to... Maybe it's a question.
Hi, my name's Sebastian Traub. I'm from the 51st state. Just wanted to, my question ties in actually with the previous one, is how to integrate all these findings in clinical practice. It would seem perhaps excessive to start dual vasopressor when you have someone come in relatively mild sepsis, for instance, severe cystitis. They come in, they have been sick for a few days, they're definitely hypovolemic, they will respond to fluids, but you need to buy some time and you start norepi, and in 6 hours it's gone already. Should I have started vasopressin then? Probably not. I wonder what your thoughts are.
I fully agree. So you see those patients that so we start earlier with the vasopressors while resuscitating the patients now. So it could also be that when you take 1 or 2 hours that you have more fluids in the patient that you already can reduce the norepinephrine. So that's maybe not the patient group you want to target with 2 vasopressors. What is also striking, I saw in the data from Professor Bellomo, but also in our data, it seems that the non-responders have a more steep increase in norepinephrine. So I think that could be also a clue. Is there some kind of, slope or so we can find out who identify those patients that need maybe a second vasopressor? But I totally agree. So maybe we should not go to moment 0, but maybe start within 3 hours or 2 hours, because maybe after 2 or 3 hours of resuscitation, you get some clue of is this patient are going to stabilize. But on the other end, also maybe for urosepsis or septic shock patients with urinary tract infections, we have to see whether the co-administration of vasopressin also lead to better outcomes with respect to renal function or final mortality or so. Because not all patients with urosepsis have a beneficial course of the disease. Some develop multiple organ dysfunction and can be in the ICU for a long time. So it's also individual. But I agree that maybe not all the patients with a limited shock phase should be treated with 2 vasopressors.
Thank you. Is there any other question, maybe also for one of the other speakers? Please, lady, maybe the speaker can repeat the answer if you talk loud.
I would like to ask about the use of methylene blue in practice.
Yeah, maybe somebody else can answer this question. If it's okay, I'm going to leave the session because I have to chair another...
Yes, we know. Thank you very much.
Thank
you, Professor van Zanten.
Thanks. No, methylene blue acts on the nitric oxide pathway, and at the moment I can tell you about our clinical practice. We use it when we are really desperate. But there are data suggesting that, and I saw now that there are trials that are restarting methylene blue earlier, and I think that all this discussion is about that maybe we want to target different pathways, and so that could be another good pathway to target, and not when you are actually, again, desperate, because then nothing works. But I've seen it working, I have to say, in some patients. Some patients, you put methylene blue because you are desperate, and some of them, the blood pressure increases, and it helps you to reduce all the other vasopressors. But this is now based only on, I'd say, very, very few short case series, personal opinion, but there will be trials soon, I think.
Okay, thank you very much. I think all the rest is for the hallway, so enjoy your lunchtime. Thank you very much to the speakers and the audience. Enjoy the rest of the Congress and enjoy Brussels. Thank you, colleague, for co-chairing. Thank you.